Dadra Nagar Haveli, Gujarat and Rajasthan. In fact, Rajasthan, quite early we converged their 75 lakh families with the SECC families, but of late there has been some issue in terms of the complete convergence. The total families covered in Dadra is around 57,000, Goa around 35,000 plus, and these are the statistics for the other states. If we see that in fact, two states are having Goa and Maharashtra have their something that they are hosting on their platform without a complete convergence. So NHA is not sharing or any pro rata arrangement is not existing for those many families. Next, please. If we talk about the card creation, in fact, this has been the focus, and of late we have issued multiple office memoranda on this. We have been tasked by the higher offices to complete 100% saturation. And as Sir was also mentioning in the morning, that we have now got a flexibility through our governing board. Since long we have been making an arrangement of pro rata fund release based on the converged number of families, but this pro rata actually in financial terms is not a right arrangement. So what we have now gone for is identifying the families through tagging the non-SECC families which the state wishes to be funded through PMJY. So most of the states have now given us the list of tagged beneficiaries, and we have to now create co-branded cards for those beneficiary families which would now be funded through PMJY. So we would be funding 100% for the card creation, and recently, in fact, therefore yesterday only the CO NHA has given a flexibility. In fact, we would be issuing OM soon to give 20 rupees plus GST to the states, and the states may onboard any agency. State may get the card created through their local functionaries, their local human resource, or through incentivization of various NGOs or any other mechanism that the state desires so, without relying on the NHA's empaneled agencies. But the purpose of the exercise is that we all have to saturate the beneficiaries through cards, the co-branded cards, and that too we have to achieve at the earliest possible and not later than the end of the calendar year. So if we see the trend of card creation, most of the participating states here, there has been a slow progress. Recently, Gujarat has gone for a drive, and there has been a jump in terms of card creation of late, and we want this slope to increase for all the six participating states and union territories. If we see that Dadra has achieved 100% at the family level, the cards have been created with at least one Ayushman card, but at individual level there are few cards which still need to be created. Goa is hovering around 25%, Gujarat again almost 35% plus beneficiary families are not having cards. Maharashtra again, 1/3 beneficiary families we have been able to issue cards so far, and Rajasthan we are struggling with this. So this is the status, and we need to increase the numbers and achieve 100% saturation, as I mentioned. Next, please. In terms of hospital admission, again, in fact, the hospital admission, if we see 21-22 per lakh beneficiary, Dadra Nagar Haveli has shown the maximum hospital admissions. Gujarat and Rajasthan also, the numbers per lakh beneficiary families is quite high. In fact, per lakh beneficiaries is quite good. In fact, Rajasthan has recently announced 100%, almost 100% coverage universalization through a different mechanism wherein all those missing middle or the middle class or beneficiaries which are not covered through insurance can be onboarded through a co-payment mechanism. So they are showing an increase, and in fact the scheme is doing good there also. And Maharashtra, because of the structure of the scheme, the number of hospitals is restricted. So the per lakh beneficiaries, we are not getting the numbers, but at the same time the utilization and admission rate is quite high. Next, please. So in terms of hospital admission, if we see Maharashtra is showing the maximum number of, in terms of percentage terms, the active hospitals, the hospital number is restricted, but the hospitals which are enrolled, the percentage of active hospitals is good. Gujarat, almost 1/3 of the private hospitals and a significant number of public hospitals are not generating any cases, so that's a cause of concern. Rajasthan again, I don't know whether the statistics, because the stats have been shared by the state, we are not getting the direct data. So almost all of the public hospitals, we are not getting any numbers, and the participation is coming mostly from the private hospitals, and there again, a majority of the private hospitals are not participating. I would like to give a disclaimer that this is the data received from the state. It might be correct, it might not be. I would request the state of Rajasthan to please dwell on this. Next, please. In terms of fund release, so if we can see on the second column, this is the maximum central share that can be issued every year. Of that, in 2021, Dadra, or less than 50% of the share they could get, and last financial year almost 1.76, so that 70 to 80% of the share was released. Goa has not been able to get its share of fund, so we would urge the state to ensure that whatever is due to you, please make the proposals and please ensure that you are able to get the central funding. Gujarat has been receiving good amount of fund, but 21-22 last part we were having some issues, so probably this tranche was not released. So 130 crore out of the due 289 crore could be released last year. Maharashtra has been able to utilize good funds under the scheme. So out of 553 crore, they were able to get 376 and 324 crores in the previous 2 years. Whereas Rajasthan, we are facing some issues, and last year's utilization and fund release is still pending. So we could release only 100 crore rupees to Rajasthan state. Next, please. In terms of universalization, if we see that of the SECC population of 2011, since the population has increased by around 11.7% in the last decade, so these 100+ percentages would not be reflective of the actual coverage against the current family, but as against the SECC population of 2011, the current trend says that Maharashtra is having 71% of its population covered vis-a-vis the SECC population of 2011. Whereas Gujarat, the Dadra and Rajasthan have given beneficiary support of the scheme to more than 100% of the SECC numbers, and Goa is again almost 100%. Next. So this was in a nutshell the broad implementation status, and since the states would be making presentation, we'll get to know about the implementation more and the challenges that the states are facing, and how we can make the schemes work better on the ground. But I would like to now dwell a bit on the initiatives that we have taken in the last 1 year and the priorities that we would feel that the states should have for the scheme in the coming months. So the few initiatives is Aapke Dwara Ayushman. This is the foremost and the most important thing. The card saturation drive through door-to-door and beneficiary camps and other mechanisms. So we started this drive in the states of UP, Gujarat, Bihar, Assam, Chhattisgarh and MP. And already we have started this year in these few states, and in fact we are in the process of migrating to beneficiary identification system 2.0. That should be live for all states before the end of the next month, and the card drive would be subsequently expanded to all the states. Last year we had very good results. We created almost 4 crore cards in 3 months through this drive, and this year the target is almost 25 crore cards to be created before the end of this calendar year. We are creating few free Ayushman cards to the beneficiaries and also to the states. There would not be any cost of these cards because the card would be 100% funded by NHA. We have entered into MOU with quite a lot of agencies like Common Service Center, UTITSL, and also have empaneled 6 agencies. But as I mentioned, we'll be soon releasing an OM, giving a flexibility to the states to onboard any agency, to onboard any group, and we'll fund 20 rupees to the states, and the states, if the cost is coming out to be more than 20 rupees, the state can fund. If the cost is coming out less than 20, the remaining amount the state can keep to itself. So that flexibility will provide to the states. We would also like to go for an extensive IC. In fact, this talk is going on that PMJY should have an IC campaign like Swachh Bharat, and there have been multiple discussions with the senior offices also, and we are very sure that we would seek approvals and get approvals to have a drive initiated, because the scheme is suffering because of ground level penetration and capacity building. So awareness and capacity building is something that we feel is important for this scheme. Just previous slide, please. So last year also we had engaged the frontline workers. This year also these would be very, very critical for the scheme, for the drive success. So I would request the concerned CEOs and the senior officers present here to rope in the ground level functionaries of various ministries, various departments, and ensure that whatever incentives have to be given, you may align the incentives for card generation, for door-to-door drive, But please see that, and all those expenses can be booked under admin fund, but at the same time, please ensure that we are able to saturate the cards. So since January 2021, we created 4.74 crores in a period of 3 to 4 months last year, and this year the target is quite big. And as I mentioned, almost 10 lakh cards were created in a day in the month of March last year. So this we have to increase to 25 lakh card this year, and we'll definitely have one-to-one interactions with the states to understand the constraints and ensure that this happens on the ground. Next. So another thing that we have started is the e-rupee. So it's a payment mechanism that in fact was conceived by our current CEO and launched by Honorable Prime Minister last year August. So it's a voucher which is person specific, and the purpose specific aspect also is ingrained in that. When we give a direct benefit transfer for any scheme to a beneficiary, it only ensures that a person-specific beneficiary amount crediting happens, but it does not ensure that the purpose for which that money is being given is served. Whereas e-rupee is a voucher which ensures that not only the person to whom the intended beneficiary gets the amount, it is also spent for the purpose for which that money is meant. So e-rupee for PMJY, we have already started, rolled out the first use case, starting with the Union Territory of Chandigarh, and we are rolling it out in the states of Madhya Pradesh and Haryana this week. From the next month on, we would roll it out across the country. So the thing is that we have now split the cost of packages into diagnostics plus. So we have separated the cost of diagnostics from the total package cost, and diagnostics would go as a separate e-voucher. So the moment a diagnostic test is to be prescribed to a patient as a part of the standard treatment workflows, the doctor triggers that into the system that now this diagnostic test has to be taken by that beneficiary, and that goes and that hits request hits the system, and the SHA's account is debited, and a e-voucher is created which comes into the beneficiary's mobile as a QR code. So that QR code voucher the beneficiary can take to the nearest lab which would be empaneled or registered for this purpose, and direct redemption and credit into the account of that lab for that voucher would happen. So the purpose served through this would be that the beneficiary is spending out of the pocket on several diagnostic tests that happens in the current framework would not happen anymore, and the laboratory would get immediate amount into the credit into their account. At the same time, this would also enable that we are able to track the actual utilization of services by the beneficiary. So this is the purpose, and we would request all the states to please support us on this and ensure that from next month all the beneficiaries are able to avail this benefit. Next. Another thing that we have been advocating and requesting the states to implement is the Beneficiary Facilitation Agency. In fact, Rohit has been in touch with almost all the CEOs on this, and I think we have explained this in the past also. The purpose for this is, as I mentioned, most of the public hospitals are not supporting the scheme. In fact, if we see that every state would be having around 40 to 50% of its population covered under some scheme, either your scheme or our scheme. So when the beneficiaries are coming to the hospital, I think most of the, in fact, every 1 in 2 persons coming to a public hospital should be our beneficiary ideally. But the actual conversion rate in a public hospital is less than 10%. If you see any public hospital, be it small, be it big, the actual conversion into a PMJY beneficiary or the converse scheme beneficiary is less than 10%. So this means not only we are not generating the numbers or the utilization figures into the scheme, that disadvantage to the state is that the potential of utilizing the PMJY claims money, the 60% amount that is going from the state's exchequer. So the state budget is being utilized for the beneficiaries who can be otherwise funded through PMJY, and the state can save 60% of the money. So the purpose of this Beneficiary Facilitation Agency is that the Pradhan Mantri Arogya Mitras would be now the employees of this third party agency that would not only ensure that the beneficiaries are screened at the time of admission for their entitlement under the scheme. If in case they are not carrying any card, their card request would be generated in real time, and then they would be booked as PMJY beneficiaries. So what would happen is that not only we are able to increase the utilization figures in the public hospitals, at the same time your money would be saved, the state's money would be saved. The second component of the Beneficiary Facilitation Agency is ensuring that the claims are submitted on time, and the claim money, in case there is any query raised on the claim, that query is also resolved on time. This would happen because the beneficiary facilitation agency would get paid only on the basis of the claims which are reimbursed to the hospital. So based on the number of claims reimbursed, the beneficiary facilitation agency would get its payment. Till the time the claim money comes back to the hospital, there would not be any payment to the beneficiary facilitation agency. So there will be a direct incentive alignment in this arrangement. The issues of the workforce negligence or the adequate utilization of resources not happening in the public hospitals, nobody taking ownership of the scheme, all these issues can be taken care of. And I'll show in the next slide as to how this has worked. Next slide, please. So this is just an example. We started this scheme, and in fact, Madhya Pradesh was the first state to adopt a beneficiary facilitation agency concept. We took quite a lot of the aspects of the scheme, BFA type arrangement happening in Punjab. So Punjab model was, in fact, we improvised on that and implemented it. And Madhya Pradesh started this arrangement, and as we can see, almost 100% increase in the utilization in the public hospital has happened ever since December till the month of June. We are just 6 months into this arrangement, and almost 100% increase in the utilization in the public hospital has happened, as we can see in the upper graph. Whereas in the similar period, if we see in the private hospitals, the increase has been only 40%. So even if we discount the issues caused by the lower figures caused due to COVID, there has been a significant increase in the public hospital utilization vis-a-vis the private hospital utilization. Private hospital, the increase is 35 to 40%, whereas almost 90% increase in the public hospitals only in a 6-month period. So the potential of this arrangement, we all can understand if we all implement it in the letter and spirit. Next, please. So this is another thing that we have recently started, is the green channel payment. So all these issues are intended to ensure that the providers, which are the main partners in the arrangement, and which because of whose support, without whose support the scheme cannot run or achieve the optimal figures, get the confidence. So green channel is an arrangement to honor or to recognize acknowledge the support of honest private players or the partners, even private and government providers. So what this ensures is that our IT system, based on few parameters like how many claims they are processing, whether they are resorting to any fraudulent practice or not. So there should not be any fraud case, the risk score within acceptable limits. So all these have been incorporated into the IT system. The IT system, based on the last 3 months statistics, would fetch the details of the hospitals which are entitled to get this green channel arrangement. And the moment the hospital clicks the claim submission button, the 50% of the amount due to the hospital out of that claim would be credited into the bank account of that hospital. So the hospital would get instant gratification. There would not be any delays in terms of payment, at least for the 50% of claim amount. So this would give a lot of confidence to the hospitals to participate in the scheme. So this is something that we have launched recently. It would be live. In fact, we earlier were struggling with the issue whether to have any bank guarantee for it or not. We would request the states to please accept this. Most of the states are showing some reluctance, but they should not be, because this is not an advance that we are giving to the hospital. It's a payment where the treatment has already happened. The treatment, the beneficiary has availed the treatment. We are just giving 50% of the amount, and that too for the hospitals, where we have ensured that the hospital is supporting the scheme since long, and this is a continuous phenomena, and we would have adequate control over the future releases to the hospital. So please accept this, because we do not want multiple checks and balances in the system which would restrict the hospital to participate. So we are doing away with the direct requirement of any bank guarantee, but at the same time we have ensured that there are systems in place to ensure that the hospital does not get away with any fraudulent or any wrong claim getting submitted and getting paid through green channel facility. Next. So beneficiary identification system 2.0, this would be live before the end of July in almost all states. In fact, all the states would now migrate to BIS 2.0. This is a self-assist. This supports self-assisted verification and submission of claims. We have also incorporated the concept of self-download and print of their card, e-card. Ayushman card. There would be mandatory Aadhaar authentication, as all states would be knowing that we have now ensured that nobody would be admitted without Aadhaar authentication into TMS. This system also would mandate the Aadhaar authentication at the time of BIS for 100% of the beneficiaries. And we have also enabled download and visibility of the entire village level data. Earlier only 5 records were being fetched by BIS 1.0, whereas BIS 2.0 version allows the entire village level data to be downloaded. Next. So joint review mission already live in the state of Gujarat. We have also requested all the states to kindly give us names of officers who are retired IAS officers or senior bureaucrats from your state who can be given responsibility. So it's a mechanism which is already existing in few ministries, like National Health Mission also has a concept of joint review mission. We have in Rural Development Department also such system is in place. So since we started the scheme, there have not been any systems to review it on a regular basis. It is us only as the state CEOs or the CEO's office or the SHA which implements, but there is no independent evaluation of the scheme implementation and how better we can improve the implementation of the scheme. So this is a self-check mechanism which is ensured through a system of your officer only going to the field, assessing independently as to how the scheme is working. So and he would be guiding and giving feedback to you. So there would not be any NHA's interference in the entire process. At the same time, the CEO's office would get constant feedback from senior officials who have around almost 30-year plus experience in the field to give you guidance as to how you can better improve the implementation. So this we have started in the state of Himachal and Gujarat, because we got the names from them. Mr. Tiwari and Mr. Baldi from these two states, both 85 batch officers are leading the JRMs. We would request the states to give names of competent officers who have had long career with high respect in the state. Wherever they go, the collectors or the state machinery would support them in terms of any resource support or information, and they can give good feedback to improve the scheme. So this is again where we want your support to kindly give us the names for officers leading the JRMs. Next. So these are the few IEC initiatives. As I mentioned that there are multiple more initiatives at national level that we wish to implement. IEC is something where we have not been able to achieve the way we should have so far. And most of the states have not designed any comprehensive ICT strategy. So this is lacking both at the level of NHA as well as SHAs. So we don't have much to offer here, but we can only say that we have to work together and ensure that IEC works the way it works for schemes like Jal Jeevan Mission and Swachh Bharat Mission. So let's work together and achieve better IEC on the ground. Next. So coming, these are 4-5 slides, state specific issues and the priorities. So if we see that Dadra and Nagar Haveli, it has gone for beneficiary awareness and IEC activities. Good work has started there, still a lot to do. We feel that more needs to be done in terms of private hospital participation. State is not having any anti-fraud unit in place, so this is something which is to be done on an urgent basis. The scheme should have zero tolerance for fraud. And unless you have an infrastructure or machinery in place, in fact, we are thinking of issuing an OM. What we have experienced so far in terms of fraud is that state officers are not too comfortable registering offences against erring hospitals. In many cases, we've seen that we request for registration of FIR. There are clear-cut indications that the hospital has resorted to fraud. But because once you register an FIR, you might be called in the court of law. The hospital officers are not comfortable. So we are thinking of issuing an OM, making a request to states to depute some deputy SP rank officer in the SHAs, so that DYSP can lead the anti-fraud effort, and in case an FIR is to be lodged, something. So some police officer, if he or she can be deputed and placed at the disposal of SHA. So I think a lot of things can happen. At least the deterrence would happen if the hospitals come to know that the police officer has come to SHA. Lot of things that they would have been doing, they would be afraid of doing that. So this is something that we are thinking on. We might be issuing some directives on this. Just a request, because the state has to finally take a decision. And we also need for this Dadra and Nagar Haveli, Daman and Diu, quality certification of EHCPs. No EHCP has been certified so far, so the quality program is something that we need to focus on. Next. For Goa, we are struggling on convergence. I visited Goa. I had a discussion almost more than a year back. So we would request the state to please support us on convergence. The state scheme is quite flexible. There are a lot of additional features that you've incorporated. But as we have studied the scheme, there are a lot of scopes for abuse. You have allowed co-payment on a free basis, and hospitals, in fact, are running on the scheme. There are a lot of corporate hospitals which are so I saw, and we found that a lot of improvements can be done on the scheme, and at the same time, we need to work more closely than what we have done in the past. So under PMJY, hospitals have not been supporting the empanelment just because the state scheme is very, very flexible, and there are a lot of things where the hospitals don't feel comfortable getting into PMJY. So we need to work here and ensure that PMJY scheme is supported by the hospitals on the ground. And the tagging is
mission. My colleague MD NHM and MD ABDM is not able to attend this meeting because of some other reasons. So I'll be presenting on his behalf. So our scheme, as we have been discussing since morning, it was launched in 2012 on pilot basis. Then it was extended to all initially it was launched for 8 districts, and later on it was extended to another 28 districts. So now scheme is operational for all 36 districts since 2013. We have integrated this scheme with Ayushman Bharat. The day it was launched, we have been able to integrate it very seamlessly and very efficiently. Our state scheme has sum assured of 1.5 lakhs per family per year. For only one package, for renal transplant, the wallet cover is of 2.5 lakh, and ABPMGY is 5 lakh rupees. Our scheme is ration card based scheme, and we give benefits to all ration card holders, including Antyodaya, Annapurna, Orange ration card holders, Yellow ration card holders, farmers in 14 distressed districts of Maharashtra. And for COVID time, from May 20 to June 2022, for 2 years, we had also extended this scheme to white ration card holders. So for this period of 2 years, the scheme was universal scheme. We have also sent proposal to extend the universal coverage of the scheme, and I am very hopeful that government of Maharashtra will accord the approval to this universal scheme. So currently we are covering 2.22 crore families, and if we take into account white ration card holders families, we will be covering around 2.6 crore families in the state of Maharashtra, that is whole state of Maharashtra. Sir, our scheme needs only 2 basic documents. One document is to have a ration card of the state of Maharashtra, and any of these 14 photo IDs, because the person whose name is mentioned in the ration card should be verified with any other official photo IDs. This is the list of 14 photo IDs. Next. Sir, we are issuing Ayushman Bharat cards, although the pace of issuing cards in our state is low. Because of COVID, we couldn't take the community drives, but now we are geared up for it, and we are very hopeful that we will be issuing cards to all the beneficiaries over next 2 quarters. Sir, the mode of implementation is hybrid. The scheme is totally cashless scheme. The premium paid, as ma'am has told rightly in the morning, that we have very lucrative premium of 797 for state of Maharashtra. Totally paperless scheme implemented on a robust IT platform. We have 996 common packages with 34 specialties and 131 procedures reserved for government hospitals, 1209 packages for PMJY. Out of this, 171 procedures are reserved for public hospitals. All pre-existing diseases covered. Portability is there for Ayushman Bharat beneficiaries, and we have also empaneled around 10 hospitals within neighboring states to give benefits to the people, to the citizens staying in the fringe areas. Next. We have best practices like emergency telephonic intimation. We also take intimations through emails, 100% pre-authorization, barring few emergency procedures, beneficiary empowerment through text messages to beneficiaries at 8 different stages during the enrollment till the discharge and post-discharge. So we are constantly in touch with the beneficiaries through these SMS. Pre-auth approval is done, which provides information related to free treatment of the scheme. We have made an arrangement that through our call center, the patients whose pre-auth is approved receives pre-recorded voice message. This message is in the voice of Honorable Chief Minister of Maharashtra, and every patient whose pre-auth is approved, that patient receives information regarding scheme, like what is covered in the scheme. They are not supposed to pay any charges to the hospital, and also they are entitled to get their return fare to their native through the state transport bus or sleeper train fare. We have very robust appeal mechanism. We have clinical protocols to ensure that the treatment accorded in our scheme is as per the standard treatment prescribed by the best practicing hospitals within the state, like AIMS, PGI Chandigarh, like our KM Mumbai, JJ Hospital, BJ Medical College Pune. These are the one of the best institutions in the state of Maharashtra and in the country. So we have taken feedback from the subject specialist, and we have devised the clinical protocols, and the entire treatment in our scheme is adhered to these clinical protocols. To every patient, we send a feedback letter. There is a pre-printed letter under the sign and signature of Honorable Chief Minister. Along with that, we send an inland letter where there are pre-printed questions, and patients needs to give their objective feedback when they are home. We don't believe that the patient will be giving very objective feedback when the patient is within the hospital, because they are constantly in touch with the hospital and they are under a lot of influence, because the life of their next to kin is in the hands of doctors. So we have found that when these letters are sent after 15 days of discharge, we get very objective and very valuable inputs from the patients. Our data says that we get around 40% of these letters back from the patients. Next. So we have public sector company United India as our insurer. We have 4 TPAs with us. Our Arogya Mitras are deployed by TPAs, and they work round the clock at the hospitals. We have also data entry operators like the claim facilitation agencies working in our public hospitals since last 4 or 5 years, and we have seen very good impact of these agencies in terms of getting more and more claims towards private hospitals. We have medical coordinator working from each hospital who coordinates, who is a single point of contact on behalf of hospital. We have 24/7 customer care center. Currently we are having 58 seats. It's housed in the same building, and we have appointed a vendor which is working for this center. Our toll-free number is 1555388. Next. We have empowerment committees under the chairmanship of SHIO, State Health Assurance Society. We have NABH accreditation criteria, and we grade hospitals as per these criteria at A, B, and C, and hospital gets their packages. A grade hospital will get 100% of the package amount, B grade will get 90%, and C grade will get 80% of the package amount. These gradings are dynamic. We regularly visit hospitals, look at their infrastructure, and upgrade or downgrade them as per their scenario at that point of time. Minimum bed criteria is 30 bed for empanelment. However, for tribal areas and for some remote areas, we do reduce the requirement of number of beds for empaneling. Currently, we have ceiling of 1,000 hospitals to be empaneled all across the state, and we have 282 government hospitals and 718 private hospitals. All 1,000 spots are filled. I would like to mention that Maharashtra has more than 50 private and government medical colleges, and average bed strength of this medical college is around 1,000 to 1,500. So although our number is 1,000, but we have more than 80,000 beds dedicated to the scheme in our state. So this is the sample of letter to the patient. The first letter is greeting the patient and asking about their condition, and then there is a pre-printed inland letter. These letters goes to the each and every patient's address mentioned in our enrollment and pre-authorization. Next. This is our performance. Like we have totally we have done more than 43 lakh procedures in last 10 years. Out of them, around 30 lakh procedures were done in last two and a half years. Sir, our grievance redressal rate is 90% at this point of time. It is ongoing process, so only 10% of total grievances are pending, and we resolve all these grievances within 30 days. So this is our status of BIS. So far we have distributed 74 lakh 76,000 cards. After the empanelment of these 4 agencies, there has been quite good improvement in distribution of card, and from the month of July we are planning state level drive to distribute these cards, not only for Ayushman Bharat card but for our scheme, which is NFSA based scheme, and we will involve all the ration card holders within the villages to distribute these cards, sir. So we are very sure that within 6 months we will be able to give cards to all the beneficiaries of the Maharashtra, sir. We have conducted, sir, more than around 20,000 camps have been conducted across the state by our healthcare partners. Next. So these are various awards that our scheme has won. Next. Sir, during pandemic, our office, State Health Authority, have played very major role. Maharashtra was first state to cap the COVID-19 treatment rates for private hospitals. This was conceptualized, drafted and implemented by our office. The Apex Court has acknowledged the efforts of Maharashtra during the pandemic, and this could be done only with the support of NHA, who has been accommodating all our requests during the COVID times. We have regulated rates of private hospitals through these various regulations. We regulated rates of RT-PCR, we regulated rates of CT scan and N95 masks, and so on and so forth. Next. For implementing all these rates, our office was the competent authority. We resolved more than few thousand complaints from various patients during COVID period, and around 100 crore rupees was refunded to patients as per these regulated rates. Next. We also give these many relaxations to patients who are availing COVID packages during COVID time to accommodate the additional requirement and additional cost of the network hospitals. We give these many relaxations. Next. Thank you, sir. This was all about Ayushman Bharat. Now I would like to present on behalf of my colleague for Ayushman Bharat Digital Mission. Next. So we have appointed mission director and nodal officers for HFR and HPR. We are in the process of appointing vertical heads and project management unit. Next. Back. We have e-Shishrut platform developed by CDAC. It is being implemented in all our district hospitals at 34 districts. We have 1 crore 45 lakh ABA created. So we are also in the process of integrating the IPs, data of IPs, the insured persons in ESI scheme. Around 59 lakh IP data is ready with us, and when we get go ahead from NHA, we'll integrate these 59 lakh IPs, and we will be crossing 2 crore ABA creation target. in next couple of weeks when we get the go-ahead. We have healthcare records linked against the OPD registration. Only 249 are linked so far among these 26 lakh. We are in the process of rolling out robust implementation, and I am very sure that over next 2 to 3 quarters we will be able to integrate all the influx of OPD as and when it comes in our registered facilities. Sir, we have been able to register almost all government facilities in HFR. Sir, only one drive has been pending for last couple of months to integrate private hospitals. We are in talks with district administration and municipal administration to get these private hospitals on board, and over next 2 quarters all the private hospitals will be on board for HFR as well as HPR. Next. Sir, this is our plan, sir. Like so far, we have 1.45 crore Aabas created, and with integration of 59 lakh IPs, we will be crossing 2 crore Aabas. And we have target of covering another 4 crore, 3 crore, 4 crore for second quarter, 4 crore for third quarter, and 2 crore for the fourth quarter. So when we discussed about Mahatma Phule and Ayushman Bharat e-cards, we are planning to issue both these cards together with help of VLEs and with help of our ration cards, ration shops, and we will be able to achieve the target. Similarly, we have set the target for medical colleges, district hospitals. Sir, we have almost reached the target for quarter 1. 100% target has been achieved. For next quarter, sir, we will be achieve 100% target for private hospitals, private clinics, and laboratories, sir. So similarly, we have achieved almost 100% target for government doctors and government nurses, and in next quarter we will achieve the target for private doctors and private nurses. So only problem we are getting in HPR is that we are yet to be communicated about the verifiers for our HPR. When we get the exact verifier details, then our that process will also be catalyzed, sir. Presently, PMU team is not appointed. Process for appointment of 3 verticals is initiated, and we will appoint these 3 verticals on deputation basis from the state government officials. Sir, mode of hiring additional resources will be as per the guidelines issued by NHA. For human resources, the funding for financial 22-23 proposal will be shared soon. Our internal approval process is going on, and we'll be completing all these tasks of appointing all these 3 verticals and PME team in next 2 months. Next. Sir, this is about our platform. E-Shushruti is being used as HMIS. It is developed by CDAC. We have 4 modules at district hospitals in all 34 places of district hospitals. We have 6 years MOU signed with CDAC. Like in phased manner, state will implement the HMIS in all our regional reference hospitals, district hospitals, all our sub-district hospitals, our women hospitals, mental hospitals, and PSC and super specialty level. In all 6 districts, state has planned to implement for all the facilities. In DH, wherever HMIS is in use, having necessary hardware and IT equipment, source of fund will be NHM, PIP, and ECRP2. So in ABDM presentation by Government of India, our proposal in ECRP2 is approved, so we'll be getting funds and we'll be procuring the required infrastructure. Next. State is planning to meetings in next couple of months, and funds for capacity building for 22-23 is yet to be proposed, and we'll propose in next couple of weeks. State is planned to design and distribute additional IEC material to increase the awareness. It will have different modes like audio visuals, print media. We'll use radio and electronic media to propagate these materials. And sir, we are in the process to propose the funds for the same. Next. Thank you, sir.
Thank you very much, sir. I would request Dr. Amit Yadav, additional CEO from Rajasthan, to kindly do the next presentation. Thank you.
Good afternoon, everyone. Regarding Ayushman Bharat Mukhyamantri Chiranjeevi Swasthya Bima Yojana, I would cover mainly the 4 points. First of all would be the scheme progress and the details. Second would be the issues or points raised by the NHA. Third would be the initiatives. And fourth would be what would be the suggestion or the roadmaps. So how we could improve the insurance schemes across country. Next slide. That's the first brief of this scheme. In Rajasthan, Ayushman Bharat scheme has been launched from the 1st September 2019. Presently, it is run on the insurance mode from the last 30th January. And insurer is New India. Total population is 1.35 crores. And the HVP 2.2 is adopted. Total empaneled hospitals right now is 810 public hospitals covering CHC and the above hospitals. And the private are 815 hospitals presently. Total beds empaneled hospitals 1 lakhs, and total patients treated in the last these 3.5 years is 27 lakhs. Next slide. Rajasthan state has implemented the universal health insurance coverage, where every citizen, irrespective of their economic status, that family can get the benefit of the insurance. Almost 74% people are covered in this Ayushman Bharat scheme. Rest 15% are covered in the RGHS and the CGHS schemes. So as per the NFHS 5 report, Rajasthan has the highest across India, the families covered by the insurance schemes. And this year we have increased the risk cover to the 10 lakhs per family. And the transplant surgeries are also covered, heart, renal, bone marrow, cochlear, and their coverage is beyond the 10 lakhs because liver surgeries could not be done in the 10 lakhs. So their package is up to 20 lakhs. One thing that this year we have changed to the all public hospitals for the Rajasthan resident, there is a free treatment because this scheme covers only the IPD cases. For the OPD cases, patient has to bear the cost, whether it could be the CT, MRI cost or the lab investigation cost. So that treatment we have covered, and since packages are limited, so we have to create completely total free treatment in the public hospitals. Next slide. This is the NFHS 5 report of this year, in which Rajasthan is highest. It is not just about the families covered, because more than 90% are covered, but it is also the families who have reported that they are aware that they are the part. If you see the Indian average, 4 families, in Rajasthan 9 families. Next slide. It is the hospital admissions from the last 4 policy years. Almost 27 lakh people has benefited. And next slide. This is the scheme progress of this year. Total 9 lakh people has been benefited, and the total approved claims of 900 crores. If you see the public and private hospitals claims consumption, so in Rajasthan 60% claims are submitted by the public hospitals, but it is in amount it is 36%. So that our target is to increase the government hospitals claims up to 75%, and by amount it should be at least 60%, because we know in tertiary cares maximum treatment is given by the government hospitals. So we have to improve that efficiency, and we are targeting over that. I will brief how it will going on. Next, it's the month-wise progress. If you see the amounts wise, it's rising, but since it is a hospital empanelment is not stabilized till now, after that I expect this would be stabilized, because sustainable scheme has to be run, and this capping has to be, because hospitalization cannot raised beyond a level, because per month limited families get IPD. There is a trends earlier we have seen in the schemes that unnecessary hospitalization are done, and which is costing to the exchequer, that we have to limit. Next slide. This is the claim settlement. That is the main issues raised by the hospitals. The second and third file, it shows the 94% claims are processed within 7 days. It's the TET violations. And almost 90% claims are paid within the 7 days. One thing that it does not cover, that's why graphs, in the suspended TIDs, like the hospital found in the fraud transactions, that number is covered. That's why this violation in the claim processing and the payments, hospitals, bank accounts, issues and PAN cards, that is not. That we are creating on the MIS, after that exact report would come. Our main focus that hospitals claim should be paid within 15 days after the claim submissions, if they are right. Next slide. The status of the various activities regarding the HBP 2022, Rajasthan presently has adopted the HBP 2.22 version, and regarding the HBP of 2022 packages, we have discussion going on with our medical teams, and the new RFP we will be getting them, and so we have certain suggestions also that we'll share. Regarding the beneficiary facilitation agencies, we have empaneled them for the medical colleges. They, at their own level, they have done it. And in the Rajasthan SMS hospital, the rate is 1% of the claim value. Like average claim of SMS hospital is 10,000, so they are charging 101 rupees for per claims. That's their average. So it caters both. If the claim amount is more, then that good. But if it's a medicine claims like 2,000 claims or 5,000, it should be a percentage of that, 50 rupees, 20 rupees. Next is the DIU has been implemented operational. In the every district there is a DPCs along with the man with the machines. Regarding the enrollment drive, there is incentive given to the field functionaries to cover the missing middleman, because after 90% also 10% people are those which are still not covered. Regarding the portability status, BIS and wallet integration work is under progress. In the BIS, because of the OTPs, the Janadhar team is working over it. So I hope within the next 1 to 2 months it would be resolved, because portability is very important for the context of the poor persons, because many persons are coming within the Rajasthan and many are also going nearby in Delhi states. Similarly, data sharing with the NHA, that's the real-time data sharing is not going on. We are working on it. Regarding the frauds, state is doing own SAFU IT activities, and after the integration, NAFU triggers will also be incorporated in it. Next slide. Regarding the fraud triggers, how we are working, I would brief on that points. In the last O&M issued by the NHA, we have integrated the SMS. It's sent to every beneficiary during the pre-auth claim submission, claim approvals, so that he could aware how much wallet amount is deducted from him. Similarly, SMS is also shoot to the doctors who has treated, because certain times doctors has been changed, so that we are doing. Tally audit of all beneficiaries are done, and it is also giving us the complaints how many patients are money charged cases, and certain times the hospital has done another treatment but uploaded the claim of different. Like certain procedures are restricted, they do that treatment, patients claims different submit karte hain tele audit mein. Next, regularly feedback is taken by the SMS based review system, so how this scheme is working. So certain hospitals who are performing good means those who are bad, that means hospitals are not taking care well of the patients. SAS dashboard has been developed for the monitoring, evaluations and triggers. Regarding the regular review of the hospital empanelment criteria we are doing, that's why in the last we have changed the criteria also for the hospital districts where the hospital's number is more than 15. We have increased the bed minimum for the 30 beds, because any district, if it has 30 hospitals, 15 hospitals, that is sufficient to cater to that people. And regarding the unnecessary booking, in ortho we have find out many osteotomy packages, microdissectomy packages are unnecessarily done and they have no good outcome on the patients. So we have reserved that packages and changed. Similarly, ICU without ventilator packages, most common like in the diarrheas, vomiting, there is no relevance of ICU without ventilator. So these are unnecessarily booked by the hospitals. Similarly, our TMS is integrated with the HCM and the BIS. And during the beneficiary identification, we are doing on the basis of biometric verification with Aadhaar authentication and the live photo captures. Certain inputs would be required from the NHA for the after integration for the NAFU triggers, and the inputs could be shared how we could strengthen the fraud IT system, because this is the most important thing if we broaden the scheme base. Next slide. This is the dashboards that we are following. First is the claim funnels. How's the claims? What is the losses? The brown graph shows that's the TIDs are booked, but the claims are not submitted. That's mainly the government hospitals. Similarly, in the right side, lower side, that's the district-wise beneficiaries where are going from one district to another districts and which hospitals are giving to identify ICRs and other parameters. Next slide. Regarding the beneficiary identification, state using on beneficiary identification system with live photos. Regarding the beneficiary awareness and the IC activities, apart from increasing the enrollment by giving incentive to the field functionaries, in the last Gram Sabha meetings, because we know every poor people in the villages are not able to get the IC awareness. So we have added the agenda of the health insurance schemes, details in the Gram Sabha agendas. So in every Gram Sabha, they were told which are the hospital empaneled in nearby districts, which are the modes of getting benefits, what card they have to bring, where they have to make complaints if they get not able to get the treatments. Because Gram Sabha, by IC, by Gram Sabha, we are able to reach the last man in the villages. Next, for the hospital engagements, regular modifications in the HEM guidelines is done, and the regular discussions with the hospitals is also done, so that they could tell what are the challenges they are facing that we could work upon. Regarding the improvement in the claims in the public hospitals, we have done four things. First of all, because hospitals we are not able to assess the performance of the medical colleges because they are so huge. So during the claim discharge, we capture the unit and the department, and this is available on the dashboards. So like SMS surgery department has 12 units, so they could see which unit has performed how much. So that is regularly reviewed at the secretary level every monthly. That's a fixed schedule, so that every department remains on the toes that they have to submit so much claims. On that basis, we are able to achieve from the progress from 30% to the 60%. And similarly, 20% incentive is given to the units, since units are captured, so they could identify, get the reports, that's how much claims they have submitted, and on that basis they could procure the small infrastructures. But still there are many challenges in the government hospitals, like the supply system is still weak. Because of that, a patient get many times abscond to the private hospitals. One thing we are going for integration of the IHMS and the TMS. Rajasthan state and except SMS, all hospitals are using IHMS, that's the hospital management system, and the our TMS. So we want that when patient get admitted to the hospital IPD counter, by the same time TID get created, so that patient does not have to go another counter for the claim submission. Similarly, when patient get discharged from the hospital IPD system, IT system, it get discharged. So that real time, only hospital and have to submit the claims from the TMS portal, rest patient has to go only on one counters. So that's we are going make it live within the next 15 days, and it will improve our almost, we are expecting 20% claim submissions, because the patient losses will be decreased by it. Next, the schemes convergence. Since this is schemes for the non-government officials, there is a RGHS schemes for the Rajasthan government health insurance scheme. Similarly, life insurance, because every family who is covered by this scheme is also getting benefit of 5 lakh rupees life insurance, and the free treatment is given to the road traffic accident victims for the 72 hours, because it is a precious time. So irrespective beneficiary kisi bhi state ka ho, we are giving the 72 hours free treatments. Next slide. I will brief how the convergence is going on. Regarding the Mukhyamantri Jeevan Rakshak Yojana, all roadside victims are given 72 hours free treatment. Hospital has to just upload the live photo of that patient with the trauma and the details of the clinical details, where he has accident, which is the nearest thana to whom he has intimated. On that basis, that hospital could start the treatment. There are 182 packages we have identified, from which almost 70 packages which any MBBS doctor could do, like the dressings, tracheostomies, acute pain treatments, and other as the intensive that could be done by the orthopedicians. So that would help to save the lives, because in Rajasthan, roadside accidents are one of the highest in the country. Second, in the Rajasthan government health schemes, there is a cashless OPD with the empanelment pharmacies, and apart from it, treatment up to 5 lakhs. Similarly, Mukhyamantri Chiranjeevi accident insurance schemes. So all those beneficiaries who are covered are entitled for the 5 lakh death insurance and 3 lakh disability insurance. Similarly, Nishulk Dawa Yojana that provides free treatment in the hospitals. Next, after making the scheme universalization, that's one common complaint during the COVID. We have analyzed that there is a denial of treatment and the money charging complaints. And since the denial of treatment is the main issue that need to be tackled, because patients when going for the treatments, either he would get the treatment or he would get treatment from own money. So to check that, we have deployed one person in all hospitals where the per patient footfall is more than 10. So that patients help either to ensure that that hospital give them treatment, or if that hospital is not empaneled for that specialty, then he would refer him to the nearest facilities. And it has helped a lot in the decreasing the grievance at the our scheme. Similarly, we have made provision because after making universal, patients or the families of the upper economic status are also get, so they many times say is that we want the private wards or the semi-private. So but for that we have allowed the OTP based consent, so that they could raise the consent that I want to go for that wards, and the hospital has submitted their room rent charges. So medical charges, they are getting benefit from our schemes. For the rooms charges, they could get. Similarly, like in the TKR, THR surgeries, many people are going, so they need the separate cares. Similarly, for the fit functionaries, 100 rupees incentive. One thing, many times we see that saturation is missing, despite knowing NFSF families, but 5 to 10% or 1 to 2% people are so poor that they are not able to register despite being poor. Either they are not aware or because of the documents they don't have. Like in the urban areas, if you could see many people's street vendors, or we could see the people's जो भी रोड फुटपाथ पे सोते हैं, they don't have the cards. तो इसीलिए last budget announcements में collector has been given special approval power that who finds that patient could get benefit, he is eligible for enrollment, then after visiting the hospital he give the shapath patra self enrollment that I am the beneficiary. Hospital district collector get check on, so patient can get start treatment, and the enrollment in that eligible category that could be later on, because the giving treatment is required and the most needy person could get benefit from it. And in our maximum benefit is, I think, in the Jodhpur is getting, because many patients are going to the AIMS, and since AIMS is also chargeable cost, so there they are very much using that benefits, because poor people always reaches to the public hospitals. Next one. Key challenges and issues that we are facing. First of all is the BIS and wallet integrations, because if it is done, then the issue of the portability could be resolved, because in our hospital of SMS and the Bikaner, there are many patients from the UP, Bihar and Haryana are coming, and from Punjab. Next point is HBP revisions. I request that it should be an annual exercise at the one period of time, irrespective of giving it every 6 months or 3 months. And second would be NHS should share the burden of the increased prices. And one thing I want to raise regarding the HBPs, we have to identify what is our goal. Whether we want to improve the district hospitals in the tier 2 or tier 3 cities, or we want to promote the hospitals in the tier 1. Second thing, as per NHP policies, this health policy of 2017, these health insurance schemes are to strengthen the public hospitals, and for the time being, we are taking help of the private hospitals. Since in every district we are opening now medical colleges. In Rajasthan, in the next 3 years, I think out of 33 hospitals, in 30 there is a medical college. So we have to make packages as per, so that the public hospitals footfall get increased, because otherwise we are just boosting the private hospitals without the raisings. Apart from it, certain good things are done in the HBP rates. Like earlier they were focused on only on the treatment aspects, but now they have gone how we could improve the outcomes, so that they have added the follow-up packages. Similarly, in the neonatal screening packages has been added. Similarly, in the normal deliveries has also been added. That was earlier missing points. But still certain things we have to look upon again need to be, like in the implants, the costing of implants are very high. In CGHS for the cardiac stents, because one of the most costliest packages used across India, I think, that would be cardiology, and that is the stents. So in PTCA, in CGHS we are paying 23,000, but in our scheme earlier it was 31,600, and now we have raised it to 34,000. So after GST it is 36,000. Paying beyond almost 10,000 rupees, 13,000 rupees is not worth, if we see. Similarly, for the high-end drugs has been added, because giving the payment for the costly antibiotics would increase further their misuse and it will lead to antibiotic resistance. Similarly, for the chemotherapy drugs, there is issues in the rates. And one thing is ICU without ventilator, that rate has been exorbitantly raised, and that is the most upcoded package. Similarly, there are these issues I will also share with you, sir, the packages. And one thing, sir, interventional radiology should be removed because it's very costly things and it should not be added in the schemes. Not removed, but the basic package should be part, because in the latest revision, package of 4 lakh, 5 lakh, 6 lakhs for the stroke has been given. It should be at the preventive checkup that we should boost at the 1,000 rupees, like cardiac follow package that we have added. Similarly, for the stroke, we could preventive checkup packages we could promote. Yes. One thing, sir, regarding the central and state contribution of 60-40, it should be in the true spirit. It should be on the basis of the actual premiums, because different states has different premium. By capping of 5 lakhs, whatever premium comes, it should be shared so that beneficiaries clash would be decreased, so that SCCC would be that names and for the other states own. One thing, sir, regarding the NHS support would be required for the NAFU triggers and the SHA IT system strengthen that we are expecting. Next slide. Our future roadmap, what we are trying to do in the next 1 year, first is IHMS and the TMS integration. First point, because hospitals IT system is still now not integrated with the insurance, our TMS system, we are not able to boost the claim submissions. So first of all, we are integrating so that patient does not have to go in the 2 queues. Similarly, our HEM and the hospital professionals registry, like the RMC doctors, because that is not integrated. Many times, doctor has left that hospital, but his name would be remaining in the HEM portals. And the hospitals are booked claim on that behalf of that doctors. That we are going to integrate, so that real-time doctor would remove his name from that empaneled hospitals. And third thing, regarding the claim submission by the public hospitals. After MDP revisions, we have given relaxation for the public hospitals in the claim submissions. So we are focusing, because lab values are created in the metadata, drugs are consumed are also. Just by entering the discharge summary, we could submit the claims on that basis, and that would be the best way if we could go in the third phase. Based on that, we could think upon about the auto adjudication of the claims. And apart from it, for the evaluation of the scheme, after investing so much by the state government, WHO and the IHMR are independently doing the impact assessment of our state schemes. So how it is impacting, what is the impact of out of pocket, and also the catastrophic health expenditure, whether it is able to decrease or not. Similarly, state health accounting exercise is also going on, like the national health accounting exercise. It would be able to tell us on which component of the health costings that we should focus, and able to tell us to make evidence-based policy makings. Next slide. One suggestion, sir, if we could think in the cardiac stents, because there are multiplicity of stents from the Indian meds that are available from the 10,000s to the 30,000s. So we have to regulate the pricing and the quality that is missing, because we are not able to capture, because we are capturing the barcodes, but there is no standard from where which we can identify. Like we are giving 300 crores out of 30%. If we could identify the outcomes after 3 years or 5 years, what is the outcome of that states, of that implant or consumables? If I would able to explain, like TKR में अभी जो हम सर्जरी या इम्प्लांट दे रहे हैं, एक हॉस्पिटल 3rd क्लास इम्प्लांट लगा रहा है, अच्छा हॉस्पिटल 1st क्लास लगा रहा है, अगर वो क्वालिटी लो का रहा और 3 इयर्स बाद फिर हमें रिवीजन टीकेआर का पे करना पड़ेगा, अल्टीमेटली आउटकम इंप्रूव हो नहीं रहा है. और वो हमें यूएस एफडीए का जो कॉन्सेप्ट रहता है, वो पोस्ट मार्केट अप्रूवल उस डेटाज को यूज करते हैं और उसके बेस पे जिस कंपनी के अच्छे नहीं होते उनके करते हैं या रिमूव करते हैं. आज इंडियन मार्केट के अंदर फार्मा कंपनीज को कोई चेक नहीं है वो किसी क्वालिटी का. knee replacement मतलब one package for the basic and one for the revision, but many hospitals because standards की define नहीं है. But the problem US FDA is in वो I got the point. हाँ, that are missing because in NHA if it is done, then it would be because strategic purchaser if you see, then we have to go on that, because otherwise we are boosting the rates of the pharma companies and insurance is using that payment rates. Similarly, in the co-payments, since Ayushman Bharat is catering only to the SCCC families, we could open at the premium rates to the other families if they want to go and they pay. Because 40% population is covered, and many people who are poor or missing middlemen, they could buy own payment, they could go. Otherwise, they have to purchase the costly health insurance schemes, and they have to bear the burden also. So, next point is the free treatment for the scheme beneficiary in the all public hospitals should be done. Because otherwise the hospital will not go for the increasing submission of the claims. Because beneficiary should feel entitled that if he go in the government hospitals, he would get the free treatment as an additional advantage. So that would raise the incentive. One thing, convergence of funds from the various schemes could be done. Like the RBSK, in RBSK, Rashtriya Bal Swasthya Karyakram, these cardiac surgeries are done. If we could convert that fund into the insurance schemes, that would give the boost. Because otherwise we are giving that fund to the RBSK team also. Similarly for the GSY, normal delivery funds could be given here. And similarly for the ESI schemes. And so one thing that I need to bring in the knowledge, after making the free schemes, there is issue of the moral hazard also. Certain hospitals are bringing the patients, paying, and they are submitting the fake claims. So we need to tackle how we could go, because that is a major risk, especially in the after small remote areas. After we have given the relaxation, hospital does not have that system. So two things that need to be done. One is health informatics audit. Hospital ka IT system ka audit we need to done. Because after identifying certain hospital, we find that the report that they have submitted for the claim processing, that report is first. And if that report is first, then we could not identify that actually that is. Because basis of the treatment is that report that hospital has uploaded, and when it is first, so that's the issue. Similarly, so we need to make standardized documentations so that if any hospital is empaneled, he has to minimum mandate such type of quality claims like OT register, IPD register, drugs, these things. If we could define at the national level, that would help all states. And so one thing after in ABDM, if we could incorporate the supply chain, how we could improve in the public hospitals. Because in many public hospitals, many times supplies are missing. So if we could improve in the IT systems, this thing, that would help the patients a lot. Thank you so much.
Thank you very much, sir. Well, ladies and gentlemen, NHA would like to first state the state official. Herewith invite respected I invite Dr. Sharma sir, CEO NHA. The problem, sir. Thank you, sir. Please come. NHA would like to first state the state official. We will be doing it by Dr. Sharma, sir, CEO NHA. The mementos have been awarded on behalf of the ACS. Starting with Dr. Nilima Kerakata. Dr. Sudhakar Shinde,
दूसरे स्टेट को कॉल करो ऑन बाबू
Sri Ravi Shukla, okay. Dr. Kedar Raikar, Nodal Officer, ABDM Goa. Dr. Amit Yadav, Additional CEO, RSH AA, Rajasthan. Dr. VK Das, CEO, ABPMJAY, Diu and Daman, Dadra and Nagar Haveli. Mr. Srinath Devatraj, Srinath Devatraj, Mr. Dilip Kavatkar, General Manager, Maharashtra. Dr. Bahubali Nagaonkar, Chief Medical Consultant, Maharashtra. I request Dr. Kanchan Kalavle, Dr. Aparna Makwana, please be ready. Dr. Kanchan Kalavle, Senior Manager, Maharashtra. Dr. Aparna Makwana, Senior Manager, Maharashtra. Dr. Neha Panchal, Senior Manager, Maharashtra. Yes. Ms. Madhvi Chamal, Senior Manager, Maharashtra. Dr. Kalpesh Patil, Manager, Maharashtra. Dr. Srinath Pundarkar, sorry, Dr. Srinath Pundakar, Manager, Maharashtra. Dr. Nitin Patil, Senior Manager, Maharashtra. Dr. S.G. Jain, Assistant Director, Gujarat. Dr. Shailesh Anand, General Manager, Gujarat. Ms. Dikshita Borkar, Operations Manager, Goa. Mr. Pavan Kumar Raikar, Operations Manager, Goa. Dr. Yogesh Poddar, Medical Management and Quality Manager from Goa. Mr. Gyan Sharma, Mr. Gyan Sharma, Rajendra Sharma. Dr. Rajendra Sharma. Dr. Rajendra Sharma, State Nodal Officer, IT, Rajasthan. Mr. Akash Agarwal. Mr. Akash Agarwal, Consultant, IT, Rajasthan. Dr. Meghal Shah. Dr. Meghal Shah, Union Territory Nodal Officer, ABDM, Dadra and Nagar Haveli and Diu and Daman. Thank you. Thank you very much, ladies and gentlemen. I request you to kindly have the lunch has been served. I request you to kindly move forward towards this section where the lunch is served. We'll meet back again at 3 p.m. sharp. Thank you, everyone. Just before you go, everyone, if you want to keep the memento in a box, there is a box located here. Please come here and take the box so you can place the memento in it safely. Thank you, everyone.